Is that the same jacket from last time?
Yeah, I don't know if it's the same shirt. I didn't look back. So
I don't think so. Is that your podcast jacket?
yes, now it is.
It now is. All right. Let's get into it. What's going on, everybody? My name's Adel, sports neurologist at the UCLA BrainSPORT Podcast and program, and backed by popular demand, due to popular demand, Dr. Kevin Bickart, sports neurologist at the UCLA BrainSPORT program and neurobehavioral specialist, and my personal CTE guy. That's what I tell people you are to me.
Good to be here.
All right, so today's topic is going to be CTE, also known as Chronic Traumatic Encephalopathy. And the reason that we're dedicating an entire episode to this issue is because it's a huge issue, right? So, and I'll let you get into the definitions and all the details as to what CTE is, but basically it's a neurodegenerative condition, right? Like Alzheimer's disease, that seems to be more frequently found in football players and those people competing in contact sports, right? Mm-hmm. And combat sports for that matter. And the reason it's important, I think, is because current athletes want to know, am I putting myself at risk of, developing some sort of dementia or something like that, which I think is a logical question to ask. And then also some of the younger guys, right? College, youth sports, right? Are they at risk of something? And I think as a parent, right? I'm not a parent, but someone that was a parent, that's a huge question for them, right? Am I putting my kid at risk of something? Not only a dementia, but maybe something else that, they don't know about, that ideally, they wouldn't necessarily find out after the fact, right? So I think, I want to start with you giving us like a brief kind of overview, big picture stuff of what CTE is. And then, also the media's caught on to this topic because it makes really good headlines, right? Anytime like an elite pro football player dies or anything like that, they examine his brain under a microscope and then they find CTE, right? So that makes really nice headlines, especially if that football player was struggling with some stuff later on in his life. And it's pretty much been a media firestorm every time something like this happens. And the media puts out, certain information that I think, us as we kind of understand the field of CTE a little bit more than the general population, but we've invested like 6 years of our life to being able to do that. But we want to put out the appropriate, accurate information so that people that have all these questions, right, so that they can make educated decisions, right, not based off of some media headline or anything like that. So we'll start out by you giving us a definition, and then we'll go over actually I think the most high-profile case in the last couple of years of someone that was struggling with some mental health issues later on in life was a football player, and then at autopsy they examined his brain. They found CTE, namely Phillip Adams, right? And then we'll also go over an article and kind of really just translate a lot of the information that's being put out for people, right?
Sounds perfect.
Awesome. So do you want to just give us a nice overview picture of what CTE is?
Yeah. So I think your setup was right, that in general, people who are subjecting themselves to sports that involve head impact of any type are starting to become concerned that head impact could lead to chronic consequences. And in the sports that involve repetitive head impact, even if that doesn't include a concussion, but just head-to-head impacts or head-to-ground impacts, have that concern now more than ever. So at BrainSPORT's clinic, we see patients and their family members get concerned after symptoms arise related to the timing of a concussion or the timing of multiple concussions in one's life, or a history of repeated head injury exposure from boxing, football, hockey, and a variety of other sports, as well as war. And those questions largely are unanswered to date by the scientific literature. And so at this point, we're making decisions and judgments and recommendations based on our knowledge of brain health.
Right.
And I just kind of want to put that out there because at the end of the day, there's a ton of good science out there about concussion, repetitive head injury, CTE, and there's massive amounts of gaps in our knowledge.
Right.
And so when we kind of clear the air about that, I think there's actually glimmers of hope for people who have chronic symptoms after a career of playing NFL football, or a career of military service, or even a few concussions as a college athlete. There's a ton of hope about what one can do that is evidence-based, that is scientifically backed, to optimize their chances of having a long, healthy life with minimal, if any, dementia-related symptoms.
Right.
So I think that's the foreshadow to the end of this podcast. I really want to kind of get to that piece. What can we do today? But let's talk about CTE.
Let's do it. Yeah.
So,
get into it.
And as a disclaimer, I'm not an expert in CTE. I'm not a neuropathologist. I'm a neurologist trained in neurobehavior, as you said, and TBI. And so my reading of the literature and following the cases over time and seeing patients with different types of dementias gives me some perspective. And so I'll talk from that today. And obviously there are questions and things that I don't know and science doesn't know. And so we'll try to shed some light on that. So CTE is a pathological diagnosis, and by that I mean a diagnosis made on autopsy of the brain after the brain is prepared and looked at under a microscope with certain dyes to pick out pathological proteins and where they deposit. A healthy brain should have no pathological proteins or minimal, and a diseased brain from a neurodegenerative condition like Alzheimer's or frontotemporal dementia or Parkinson's has, as per the diagnostic criteria, a pathological protein, a misfolded protein that builds up and kills neurons or brain cells. And from many of the other dementias, we know that that is a progressive process that starts in one part of the brain and either spreads or accumulates in different parts of the brain, causing the symptomatology of that neurodegenerative condition. So for CTE, at this point, all we have is cross-sectional studies of autopsy cases where people at different ages died from one reason or another, had exposure to repetitive head impacts like through NFL play, and then were diagnosed as having this CTE pattern of pathological protein buildup in their brain. And the fact that age is correlated in this cross-sectional cohort of studies to the abundance or amount of CTE pathology, it's thought that this is a progressive condition. But we actually don't know in life, because we can't diagnose the condition accurately in life yet, whether it truly is progressive, how quickly it progresses, and in whom it progresses, how to stave it off, how to prevent progression, how to prevent onset. So I'll say at this point, just to be absolutely clear, it is a pathological diagnosis, and it is more commonly found in people who have had a history of repetitive head injury exposure, like through combat sports and other combat activities.
Now, so just to be clear, cross-sectional means you can't actually assign a timeline to it. Certainly there's, how do I put it? There's sort of, it kind of points to that there might be a progressive nature to it, right? If there's a cross-sectional where you can assign, most of stage 1 occurs at this age, most of stage 2 occurs at this age, and that age is progressive in nature, certainly it alludes to that, but it definitely does not say that it's directly associated like that, right?
Exactly, and I think that's a key concept. This is the first piece of evidence to build a case for a neurodegenerative progressive condition.
Right.
And nevertheless, in order to prove to ourselves that it indeed does progress, we would need a biomarker that we could show evidence of this abnormal pathology at a particular age in a particular person, and that builds up over time. And so if we had a brain imaging scan that we could do in a 30-year-old that had symptoms related to what we thought was due to a repetitive head injury exposure history, and then we imaged them at 35, 40, 45, 50, and we found that biomarker on the image lit up more and more, progressed through the brain in a pattern that was discernible and related to their symptoms, that would be kind of a pathognomonic or a telltale study design to help us understand that CTE is a progressive condition.
Right.
At this point, we have people who have died at different ages, and at the different ages of increasing age of death, there's more pathology tending to be.
Right. And then in regards to symptoms, right, it seems like CTE symptoms and just generally, I think symptoms of dementia can be pretty nonspecific, right? I think we've been able to hone in on, Parkinson's, frontotemporal dementia, which we're not really going to get into much because, that'll be a rabbit hole. But in regards to CTE symptoms, they tend to be pretty nonspecific, right?
I'm going to come back to frontotemporal dementia because it actually is a relevant comparison, which we'll talk about in a few minutes. But
Sure.
The fact of the matter is trying to figure out which symptoms in a given person's life are due to CTE or retrospectively you can assign to CTE is difficult because of many limitations. One, remembering an individual's history and kind of accurately portraying that and giving symptoms in a kind of progressive manner is difficult for a family member to do on their loved one who had passed away.
Right.
And so there's limitations. It is important information, and correlating it to the pathology it's found on autopsy is critical for us to understand the condition. But it is not as good as a longitudinal study in which we track symptoms as they progress and build and change over time in correlation to a brain scan and things like that, which we have for the other more well-known neurodegenerative conditions. So symptom progression is challenging because we don't have diagnostic criteria in life that's accurate. And then the second piece is, as you mentioned, some of the symptoms that have been associated with CTE, such as the behavioral symptoms, aggressivity, impulsivity, anxiety, and violent behaviors, things like that, are not specific to patients who have a neuropathology. And are common in dementias in general, especially if we're looking at patients who are developing dementias in their later ages, 70s or 60s, but are also common in mental health issues.
Right.
And so if someone has a mental health diagnosis in their 30s or 40s and has a repetitive head injury exposure, if we were to use our current knowledge inappropriately, we might misdiagnose them as having CTE because of their head injury exposure and their new onset or change in behavioral symptoms, and that could be damaging. I'm sure we'll get to that.
Yeah, and then I do want to set context to how these studies are done in CTE, and maybe you could shed a little bit more light on it. It's brains are donated, right, to whatever organization that's currently doing the autopsies, and they're usually donated because this person had a history of repetitive head injury, whether in football, whether in hockey, whatever sport, right? They say, and they also had some of these nonspecific symptoms later on in life. So they said, okay, take a look at his brain, right? And look for CTE, given them looking back on their symptoms, as well as them having a history of repetitive head injury, right? This is the usual context whereby CTE is found, because you can only find CTE on autopsy when you look at the brain after someone's dead.
Yeah.
Right.
What you're talking about is called convenience sampling. And this is a kind of selective way of doing a study in which patients and their loved ones come to the study for a reason.
Right.
And so it's not all comers. It is by no means a generalizable sample that is a good representation of all football players.
Right.
If all football players that died were autopsied, we'd have a better idea of the prevalence and incidence of this condition, but we don't right now.
Right.
All we have is those people who decided there's some reason to donate their brain. I have to call the brain bank locally or associated with one of the universities that studies this because something was wrong with my loved one, or a patient themselves felt something was wrong and kind of enlisted earlier than death to donate their brain, and once died, the brain was analyzed. So this is a convenience sample, and it's biased by that.
So that's interesting. I always thought it was families sort of retrospectively donating the body, but people alive that are suffering with issues.
People are starting to sign up now
while they're
to donate
alive.
the brain. But some of the most covered cases where an individual write a suicide letter.
Right, and then
it's
shoots
just a few
himself
of those
in
cases,
the chest.
but
right.
just to be.
Yeah. So since we're talking about high-profile cases, let's turn to this press conference that Dr. McKee, who's an amazing neuropathologist, leading neuropathologist when it comes to diagnosing CTE after death, right? And this is in regards to Phillip Adams. So Phillip Adams was a football player that played several years in the NFL and then retired. He was a journeyman, went from one team to the next. And then afterwards, he developed a lot of mental health issues, a lot of primarily issues with his activities of daily living, right? Like he wasn't showering, he wasn't really taking care of himself, and he really just went down this spiral, and eventually this culminated in, unfortunately, allegedly, he went in and murdered an entire family, right? And then due to that huge issue, right, the family then donated his brain to the BU group where Dr. McKee is, and she found CTE, right?
Yep.
And then this is the press conference that Dr. McKee is doing, kind of announcing her findings.
Yeah.
And then we're going to go over that and we're going to translate it for people.
Sounds good.
Yeah.
So
let's get it.
And difficulty sleeping.
Phillip Adams had frontal lobe atrophy as evidenced by enlarged frontal horns of the lateral ventricle.
So there's some complicated terminology. Like, if I was a neurologist, I have no idea what that means, right? So what does that mean?
So first of all, this is a clip of Ann McKee's press conference in which she has a lot more detail around her opinion of the case and everything like that. So if you're looking for the full press conference, it's out there, and there's more detail there.
Yeah,
but frontal lobe atrophy and enlarged anterior horns of the lateral ventricles is a finding that describes the what we call gross anatomy of the frontal lobes. Right. So roughly from the ears forward, inside the brain and behind the forehead is where the frontal lobes exist. It's the most evolved part of the human brain and is in charge of a variety of functions that you'll hear Dr. McKee talk about. When that part of the brain becomes thinner, either due to age or certain neurodegenerative conditions or as related to neurodevelopmental conditions or mental health conditions, that can be seen on the autopsy as being thinner. The cortex, which is a thin layer of brain cells at the very edge of the frontal lobe, can be noticed as thinner, and so the sulci or the parts of the brain that fold in will look wider because the outer layer is thinner, and then inside the brain, the ventricles, which have fluid that run through them and act as somewhat of a cushion for the brain, will become bigger just to fill the space that is left behind by the thinning cortex. And so she notices frontal lobe thinning, and because of that, enlarged ventricles.
And generally those functions that the frontal lobe is in charge of are executive functioning, impulse control, some emotional regulation, right?
Yeah. So, I mean, the frontal lobe, I think it's a fascinating area because when we talk about these things colloquially or in the media, the frontal lobe could mean a lot of things. Yeah. The frontal lobe plans motor movements. The frontal lobe also is important for making decisions and calculating kind of risk-benefit ratio and switching rules to kind of modify behaviors that are important for a game or for kind of everyday success. But it's also important for moral reasoning and emotion regulation and impulse control, as you say. So the frontal lobe is made up of many subregions that are all important for a variety of different things. And frontal lobe atrophy is a very general term, so it could mean anything, really.
Okay. Let's move on.
He also had a large cavum septum pellucidum with atrophy of the fornices, and microscopically,
Stop it there. Cavum septum pellucidum. My understanding, it's a space that develops in between two membranes that separate the lateral ventricles.
Yeah, people can be born with this, and this is thought to develop due to shear forces from repetitive head injuries, and has been found to have a correlation with CTE pathology on autopsy. And so it is one of the things we look for when we look at a brain scan in a living human, to say whether that might be a hint, among other things, that they've been exposed to repetitive head injuries that cause some brain change, but it is not specific for that condition.
Right. Okay. And then atrophy of the fornices.
So that's
fornices is plural for fornix.
Right.
Right.
Yeah. So that is a pathway for memory and emotion, and atrophy to that pathway could indicate that there's some dysfunction in the limbic circuits.
Got it. Well, you see it normally, can it be a normal variant, atrophy of the fornix?
I don't know, to be honest. Yeah.
Really?
Yeah.
Okay.
He had very dense and extensive tau pathology in a pattern and distribution diagnostic of stage 2 CTE.
Tau pathology. So tau is a kind of protein, right? Take it from there.
So I'm no expert in tau, but tau is a protein that is normally found in neurons and other cells that provides framework for the cell. And in certain conditions like Alzheimer's, frontotemporal dementia, other tauopathies or conditions related to tau problems, the tau is misfolded or misshaped and builds up and causes the death of the neurons in a pattern that's consistent with that particular condition. And so in CTE, the tau, the pathological tau or abnormally shaped tau, builds up in specific areas of the brain that, according to Dr. McKee's work, is diagnostic of this condition, CTE, and not of other tauopathies, other conditions that also have tau or abnormally shaped and folded tau.
Got it. And if you're looking at that, it says p-tau because that refers to phosphorylated tau,
Yep.
right? The phosphorylation of tau is like just a process that has to happen for it to be abnormally deposited in the brain. All right.
Mr. Adams' CTE pathology was different, however, from the other young NFL players with CTE. It was different in that it was unusually severe in both frontal lobes.
So she says, so first off, he has stage 2 CTE is what she said previously, right? Which again, it hasn't been established that that's a progression, right? We just know cross-sectionally that stage 2, the burden tends to be more than stage 1 and stage 4 more than stage 3 and so on and so forth. And then she mentions abnormal deposition of tau in the frontal lobes.
It's abnormally, she describes it as abnormally severe for stage 2, which is not the severe stage of CTE pathology. The severe stage is stage 4.
Okay.
And so stage 2 is by definition not the severe stage.
So, but again, isn't severe like a subjective term? You know? Unless there's like guidelines.
A neuropathologist does not use severe subjectively.
Okay.
Nor would a neuroradiologist or anyone who's looking at a neuroimage or of a brain scan or of a histological slice of an autopsied brain. Severe is a semi-quantitative term that describes, the number of whatever it is you're looking at, or the kind of degree of atrophy, for example.
Don't you think?
In this case, she's saying key thing: severe predominance in the frontal lobes.
Right.
Whereas other cases, and there's plenty of literature on this, the distribution of tau pathology in the various stages of CTE. It's not like it starts in the frontal lobes and spreads back or something like that that we know of. It is more in certain regions of the distributed cortex, not just frontal, in the cases on average that have been studied. And so a few cases that Dr. McKee will describe also have, at stage 2, more CTE pathology in the frontal lobes rather than more distributed throughout the cortex. Right. So that's what's odd about this case. Not that it is severe. It's that the CTE pathology is more in the frontal lobes than it is elsewhere.
Right. But don't you think it's interesting that a clumping of tau in the frontal lobe seems to correlate in this case with frontal lobe atrophy? So doesn't that tell you, okay, well, it's also clumped in the front, but then also the brain, it seems to be degenerating the brain in the frontal lobe as well.
I think that's a reasonable assumption. The problem is then taking that and assigning all of his behaviors to atrophy or all of his behaviors to the clumping of the
I'm not doing that. I'm just saying.
So I think that's a reasonable assumption.
It's reasonable. Okay.
Yeah.
All right. You want to keep going?
Yeah.
Yeah.
Its frontal lobe predominance, Adams' CTE pathology was similar to that of another young NFL player, namely Aaron Hernandez.
You know Aaron Hernandez?
Mm-hmm.
Yeah, so do I. So for people,
I know his case. I don't know him.
Yeah, I don't know him either. Thank God. But Aaron Hernandez was, for people that don't know, Aaron Hernandez was a NFL superstar for the New England Patriots that, for some reason or another, ended up murdering people and then being convicted for it, and then he committed suicide in prison, right? And then so she says, because she actually did the autopsy for Aaron Hernandez too, and then ended up coming out that Aaron Hernandez had CTE as well, and she did the autopsy for him, for Aaron Hernandez, and she's saying that in Aaron Hernandez she also saw that similar sort of clumping of tau in that frontal lobe.
Right.
Yeah. What do you think about that?
I mean, that's the observation. 2 cases with murders and frontal lobe predominant CTE pathology is what I heard.
That's it.
And
yeah. But that's
then,
all you can make of it, though.
Yeah.
Right?
Then extrapolate, causality from that is too much, and so we'll kind of try to thread that needle.
Right. Okay. Let's keep going.
Severe frontal lobe pathology might have contributed to Adams' behavioral abnormalities in addition to physical, psychiatric, and psychosocial factors.
And then that's it. That last thing that she said his frontal lobe atrophy might, the key word I'm sure is what you're going to hone in on, but might have contributed to his behavioral issues, aka impulse control, everything that was found, right, in terms of his behavioral issues.
Yeah, and I agree with the use of terminology that it might have, and it's a reasonable assumption that CTE played a role. And I think where the challenge is deciding how much CTE played a role, and if we say CTE caused the behavioral abnormalities solely, and or was a major or the contributing factor in the behavioral change in this individual, then we will view other cases that same way, and individuals who are experiencing similar changes will view themselves that way. And I think that's where media portrayals of what Dr. McKee said can become dangerous. And so I'll give you kind of like a perspective on this from my point of view is that frontal lobe atrophy is extremely general. The frontal lobes are involved in a ton of things, as we've described. And in patients with frontotemporal dementia, for example, a well-known neurodegenerative condition that's been studied in life and in death and has a clear and fairly accurate diagnostic criteria for life and has symptoms associated with frontal lobe atrophy by the definition of the condition. It affects both frontal and temporal lobes, but it usually affects the medial temporal lobes, the kind of middle portion of the temporal lobes, and the orbital frontal lobes, the part right above the eyes. Mm-hmm. As opposed to later in the condition, it affects the lateral surface towards the outer forehead area. And so because of that pattern of atrophy and that pattern of neurodegeneration, the symptoms take on a specific progression. And so starting with symptoms of disinhibition, impulse control, apathy, loss of empathy, and kind of some odd eating behaviors and things like that. That is all also due to frontal lobe, but rarely do you see aggressivity or violence or psychopathy. It happens in these conditions, but not in everyone. And if we looked at an autopsy of an individual with frontotemporal dementia, we would certainly see very severe frontal lobe atrophy in those key regions that we discuss as important for emotion regulation, impulse control, and all of these things. But rarely do we see aggressivity, violence, and other behaviors that would lead to murder. So you can't just say frontal lobe atrophy causes or is a complete explanation.
Right.
And then I'll just take it one step further outside of frontotemporal dementia and say that to the best of our knowledge to date, understanding the neuroanatomy of psychopath behavior or antisocial personality behavior or violent aggressive behavior puts those behavioral problems, links them up with atrophy in the ventromedial, orbital frontal parts of the prefrontal cortex rather than the lateral parts of the prefrontal cortex. And I'm saying that because still we don't know, only Dr. McKee and the others who have viewed Phillip Adams' brain know where the atrophy was, where the abundance of this tau pathology was. And if you look at an average brain and it has atrophy there and they never committed any crimes like that, you couldn't tell anything by a single case.
Right.
And so that's why I'm kind of providing perspective and caution to anyone who's reading this and has a read on their MRI today that there's a little frontal lobe atrophy or something like that.
Right.
It doesn't necessarily mean that these behaviors will develop. And in large part, these behaviors don't develop despite frontal lobe atrophy in well-known conditions that have been studied very well.
Right. So what do you think about the logic that, someone that was potentially, and certainly this isn't very complex, not complex way of thinking, but not very like medical and neuroanatomical way of thinking, but just someone that was capable of doing something like this, but sort of the inhibition of like a frontal lobe, since as you said, it's involved with inhibition. But then, going, if that frontal lobe atrophies, then potentially it sort of pushes them over the edge and then makes them capable of doing something like this.
That's one hypothesis.
Right, and that would be like the sort of that unlucky few, right? Which, frontal lobe atrophy in someone that was never really capable of doing something like this, okay. But then frontal lobe atrophy in that select, very, very small sect of people that might have been capable of doing it. I don't know.
Well, I think you're onto something, because when you talk, and Dr. McKee in her longer press conference talks about this, this is a multifactorial problem. It always is. The brain atrophy is just one way of looking at the brain's function, or one way of guessing the brain's function. Atrophy does not. Some people have atrophy in regions of the brain, and the brain functions completely normally.
Right.
And so you cannot say the brain is dysfunctional due to atrophy alone.
Right.
And furthermore, despite certain objective brain findings, there are other factors that play into people's behavior, such as prior trauma exposure, prior mental health problems, prior hit. And when I say trauma exposure, in that case, I was talking about psychological
traumatic experiences, yeah.
And so, and then genetic predispositions,
Sure.
Family life, socioeconomic status, all these things play in. There's actually a recent study done by one of the leaders in this field that describes 3 variables that predict aggressive behavior in a large cohort of adults.
Mm-hmm.
One was specific locations of frontal lobe thinning. It wasn't atrophy because it wasn't to the degree that it was more than 3 standard deviations below the normal range, but less volume in the frontal lobes in the ventromedial prefrontal areas, orbital frontal areas, frontal pole area, not necessarily the lateral prefrontal cortex, and some of the temporal lobes, the anterior parts of the temporal lobes. And in addition to that finding that predicted aggressive behavior, also separately prior exposure to assault trauma, a victim of assault, and personality characteristics of antagonizing behavior and disinhibition. Those 3 separate variables predicted aggressive behavior separately. So those personality characteristics and prior assault exposure were not related to the brain anatomy and vice versa.
So cumulatively, if someone had all those things together, would that necessarily mean that this is going to be someone that is likely going to be an aggressive person?
It predicts that there's more of a chance to have aggressive behaviors according to that study.
Right, not absolute, certainly, but higher risk, significantly higher risk.
That's what that study suggests, yeah.
Cool.
And so the point there is that it's multifactorial, and they didn't look at genetics. They didn't look at a variety of other factors that we know from other studies correlate with aggressive behaviors.
Right. No, that's excellent. That's awesome. So let's go over this article now.